So that was sort of thinking about prehabilitation. So, giving them something so they don't get infected. And particularly those patients who we have a recognised lower intestinal diversity. So I'm going to talk, and really, in terms of prevention of recurrent disease, really our biggest target is those who get recurrent urinary tract infections, which, as we all know, is a big problem. So the periurethral colonisation and migration from the bladder of uropathogens colonising the gut has been identified as a causative factor in the etiology of UTI. This is a nice picture just to show the sort of the journey of the pathogen into infecting the bladder and kidneys. And this is an excellent paper which showed that 1% of the gut abundance of E. coli was a risk factor for E. coli bacteriuria and UTI, and the same for enterococcus. So the more enterococcus you have, the more likely you are in your gut, the more likely enterococcus UTIs you're likely to get. So this is just, this is sort of where we're starting to think about could the gut be a potential target. I'm interested in renal transplant. It's clear that I like immunosuppressed people. I'm also interested in the renal transplant cohort. These are patients who are on immunosuppressants. They're immunosuppressed by the underlying disease, and they've got a surgically modified urinary tract. So they're at increased risk of recurrent urinary tract infections. They have recurrent urinary tract infections, they get recurrent antibiotics, they get repeated healthcare exposure, and they're at increased risk of multi-drug resistant UTIs. They then have a second-line therapy, so maybe not listed anymore, but glycosides and recurrent infection, and the recurrent infections both have the impact on the graft function. And this is a paper that showed that this paper shows that there was recurrent UTIs were associated with full graft and patient outcomes, as well as multi-drug resistant cases compared with the non-recurrent cases. So if you had a single UTI, that didn't have an effect on your graft function, but recurrent UTIs, particularly these patients who are prone to recurrent UTIs, had worse outcomes in their graft, and equally importantly, survival. When we look at the paper that I mentioned before that we published a few years ago, we also saw the reduction, there was a significant reduction in multi-drug resistant UTIs pre and post transplant. Now it's difficult because I'm just going to show you a few papers, but actually, where is the evidence? They've mostly been case reports, very small case series. These are just two that show a patient. I think that the pictures are nice. Again, each one is just one patient, but you can see that as soon as the patient has the fecal transplant, the urinary tract infections stop in the first, and there's a significant reduction in the urinary tract infections post fecal transplant. Again, each was a single case. And again, this is sort of further, you can see the nice black line at the top, which shows what the fecal transplant is, and the purple line, and the little red targets at the top were the infections, and it just stops the fecal transplant. Again, one case. And the one at the bottom just showed slightly more patients, but it just demonstrates the reduction in urinary tract infections. So yes, it's promising, the theory's there. There's a gap, isn't there? We've got very little evidence of it, but we feel like it should work. I could find sort of 3 proper ongoing trials on clinicaltrials.gov. They're ongoing, so it'll be interesting to see what their results show. But really, there's lots of questions about the treatment use of fecal transplant for recurrent UTIs. So who should we be targeting? Should we be targeting patients in the community who get lots of UTIs? Should we be targeting renal transplant patients? Should, if perimenopausal women are a high risk factor, but really, is that because there are sort of changes in the vaginal microbiome, again, which we're not targeting with the fecal transplant? And should we be doing this as a last? I think I've sort of should we do this as a last case scenario? So they've tried everything else. They've tried all the different non-antimicrobial therapies for recurrent UTIs. There are lots of antibiotics. Should we try it at that point? Again, we don't know. We don't know the answer. And do we need to be giving repeated therapies? These patients have got an ongoing risk. Unlike our stem cell transplant, our renal transplant patients, where they have one very definitive intervention that's going to plummet the diversity and put them at risk. They're going to have whatever's going on with them is going to be an ongoing risk. So do we need to be giving them repeat therapies? Again, all of this needs to be answered in large-scale trials. And should we be thinking more about focusing on the mechanistic studies? You know, when we look at mice models or sort of etc., we don't have much to back up our nice fecal transport theory, and we don't really know. There's just so many unknowns we don't know before we should be thinking about that. We're not sure we've thought of, except for these sort of incidental findings. Often these case reports of C. diff patients who then said, "Oh, actually, my recurrent UTIs have stopped." So do we need to there's so many more things to expand before we sort of start offering this as a treatment, which I think a lot of people do want to, particularly private in England, sort of big private public sector divide. A lot of people are offering this, but there's so many unknowns. So in conclusion, we know that the intestinal microbiota is playing this role in sepsis, in infection, and critical illness. We know that there's this role in gut barrier function, colonization resistance, and those with lower lower microbial diversity can prevent invasive infection. There is this potential use of FMT. And here we call it IMT, FMT, the same word. And we know that antibiotics drive this increased risk. So I think as our understanding grows of recurrent, the interplay between the microbiota and invasive disease, it's not just about fecal transplants. I don't want to sell fecal transplants as a cure, although that talks about, I don't want to sell it as this cure-all. We're really starting to understand more. We're starting to say, okay, antimicrobial stewardship is important, diet is important. It should be a last-ditch attempt, because actually there are so many other things that we need to be modifying in these patients, that we're starting to understand the more we understand about the microbiome, that we should, until we get to this point where this is like a transplant. So I sort of want to end it on, because I think fecal transplant has got potential in these infections, but I also think that we need to be sort of used as a holistic approach. Okay. Thank you very much.